Okay, it's 12 o'clock. Let's go ahead and get started. Welcome to the KPQC Learning Forum for July. I'm Tiffany Burrows and I will run the chat. And if you have any questions, please just let me know and I'll keep an eye on that. And I'm going to turn it over to Jill, Tara, and Carrie to get us started.
Hi, everybody. Tara Stroda. I think this is my round. We're going to take turns, though, in the coming months about doing learning forums. And I think that's nice to hear and see from lots of our team. Welcome. It's July. There are lots of vacations and staffing and subsequent staffing issues happening across Kansas. So I know that this took time for you to jump on. And so I think you're going to be glad you did. I know you're going to be glad you did today. Next slide, please. We have to talk about the spring conference because I think I'm still buzzing from seeing you all in person. For those of you that were there were 20 sites of the then 31 that were enrolled that attended, which was phenomenal. I think that's a record high for how many sites were represented there. That was 35 in-person attendees. Again, wonderful. For those of you that were online or on site, you know that we had 2 keynote speakers, very different topics, but very thought-provoking conversation that ensued both during those presentations, but also after. And direct TA. Certainly, you know, for those of you that were there, the afternoon was spent collaborating and conversating about next steps. And that buzz has continued. And many of you went home and dug deep into the next steps within your 4th trimester work. And I appreciate that. We all do. There have been some questions about how the future conferences will work. You've noticed that we've changed the term from general meeting, which is a KPQC specific title, to conferences. I think it's a more accurate term. And so when we use the term conference, please know that that's the same event that we do twice a year. We really feel strongly that we need to continue to use a hybrid option at least once a year and then one in person. As you will see, it's coming down in a couple slides. Our big, massive statewide in-person meeting is not going to be just 4th trimester or KPQC leaders or membership, which is another huge, massive piece of the state, but we're going to grab more and more and more people that are involved in maternal and infant and family care in Kansas, and excited about that potential. So bottom line is, great job for those of you that were there. I know you're hitting the ground running. For those of you that couldn't make it, it's okay, but we look forward to seeing you in October, and see the kansaspqc.org website for more pictures of that day. Next slide. Reminder is some interesting conversation I'm hearing from some sites, even those that are enrolling, to remind you that CMS continues or has started a birthing friendly designation. I'll call it a checklist item. And I put this slide up just so that you could alert your staff members, your QI people that report to CMS, if it's not you, that in fact, don't forget to tell your high-level administrators that you all are enrolled in a QI maternal morbidity specific structural measure. What does that mean? It means that your hospital then, like I said, gets a check mark on the CMS side that you're involved in QI directly related to that. And sometimes I think, as much as our champions know and communicate what you're doing, we don't tell on ourselves in a good way very often. And this is a piece that we assume your administration knows, but just tell them, remind them what your unit and your hospital are involved with, because they can report that to the national level and get a gold star. Next slide. There it is. There's the save the date. So everybody take off the day right now, Friday, October 20th. It's a full day. There'll be actually some things we can do the evening before in Salina. You'll hear more in the coming weeks, but this is our big, large statewide combination event, specifically with A1 of Kansas and our KPQC membership, but we're pulling in everybody from local agencies, statewide leaders, ACOG, ACNM, major sponsors, and folks that are going to come talk to all of us that are there that day. Your registration link will be coming soon with a full agenda. Again, take off the day now. You're going to want to be there. Next slide. 2 additions since we last met, 2 new enrollees, and we welcome them to the 4th trimester family. Clay County Medical Center, lots of buzz about your hospital, and we're so thrilled that you're involved. Actually, one of our speakers at our fall conference is coming from Clay County. I'm pretty excited to hear from Dr. Haynes. And then really, really great sign that we got from Advent Health South Overland Park. We've been talking to that hospital for a while now and so excited that you guys are on board. Know the great things that you're doing there. Next slide. So as a quick congratulations to everybody that's enrolled, and for those of you that are still thinking about enrolling, we want you. Our goal when we started the first trimester project was to hit 90% of births in Kansas, and don't blink, but we're almost there. 86% of births are now impacted by the work that you're doing across the state, which means that moms, babies, families are getting better care and better follow-up. And that is saying a tremendous amount. We know that the outcomes will change with the numbers increasing, and certainly we're doing great things by more enrollees. So we'd love to have you join us if you're not already. Next slide. One of the struggles that we know is present, and I thought it was important for me just to say the hard thing today, is that one birth center has now closed that was enrolled, and we have 2 hospitals that are on pause. Pause means that they're not permanently closing their OB departments at this point, but they are potentially facing either long pause or closure. And why is that important? It's vastly important to this group, important to the leadership team in this group. And I would tell you the sequelae from a birth center hospital closure, that information is not lost on you all. You know that that's a big deal. But, you know, as we hear about what's going on across the state, and we talk about what was already some areas of OB deserts where women were having difficulty accessing or following up with care, when we start seeing birth centers and hospitals closing or putting on pause their OB units, you can imagine the concern that we have. So we're aware of what's going on. We're in conversation with those folks. I wish I had a magical wand to fix the problems that are happening. But just so you all know, we are fully in support of whatever we can do to help you stay open. And we know that the first trimester work is a portion of that. Next slide. Rapid response. The next couple of slides are just a quick reminder to everybody about what's going on and maybe even some helpful food for thought. Had a great question, and I think it was actually out of Overland Park Regional about combining some of the first trimester work into their childbirth education piece. So not just the post-birth piece, but what else, she said, could we include that's really fourth trimester based, but really smartly including it in the pregnancy part of that event for her and for that family. And so I threw this slide together. This is the email that I sent back and said, you know, if there were 5 things that I really want to make sure are included in childbirth education that feeds into the first trimester education and work, these are the 5 things. And then, of course, you see the 5 things to the right connect to those 5 starter list items. And those were documents, or as you see, the post-birth information is there. So in other words, what's the toolkit or what's the resource attached to that important item? Happy to share this out. If you guys have childbirth education happening at your facility that you feel like could embed 4 trimester more, happy to, like I said, happy to share this out, but you all can do that same thing. What's important and what can we do in pregnancy education? Great idea coming from them. Next slide. And the next 2 slides, again, I'm not going to read them to you, but I just, Carrie and I, I'm going to say pride ourselves on finding hard data. And by that, I mean valid data, but also sometimes it's a little hard to read. We want to share it because it's important and a reminder of what the data is telling us. So this is an important journal article that came out in the last few months talking about maternal mortality and severe maternal morbidity in the U.S. from the dates of 2008 through 21. Keep in mind that's a portion of the middle, we'll call it, of COVID. The asterisk is important. This is in hospital data. It's not post-discharge community level data. It's in hospital data. And basically what these 2 slides highlight is the fact that in hospital mortality is down. However, morbidity is up. And how in the world is that happening? So I would encourage you all to take a look at these 2 slides, to go to the journal article yourselves and really dissect it. I'm going to make it easy for you and tell you that first bullet point on the left side where it talks about maternal easier said than done, huh? Maternal comorbid conditions, including obesity, gestational diabetes, and tobacco use. I know you're going to say, I knew that already, but those are the 3 red flag comorbid conditions that are leading to increased maternal morbidity in the United States. And all three of those are significantly increasing in that time period, followed by gestational hypertension. Again, no surprise there. Asthma, preeclampsia, pre-existing hypertension, and substance abuse disorder, which again, no surprise, but I think you need to hear what's being said. Mortality is down in hospital, morbidity is up. Next slide, please. This is just a piece that I pulled out again, just for your reading pleasure later. Next slide. And then kind of turning, but not turning, we always like to present helpful webinars, conferences across the state that we think that our membership at the KPQC level will be interested in. This is certainly a wonderful one. Our Kansas Birth Equity Network colleagues are throwing their annual summit. And so the link there leads you straight to registration. The agenda is there. It's a 2-day, but really 1-day focus for those of us that can attend. And it's happening September 15th and 16th with specifics on the website. So we would encourage you all to be there and certainly look at the phenomenal agenda that they have planned. Next slide. This is the Kansas Birth Equity Network training. This was supposed to be the big moment that I tell you all that we are ready to roll out, and that about 3 sites every couple weeks, we're going to just have everybody train your staff. And I will tell you that we've run into some IT glitches at the hospital system level. And so we're working really hard and really fast with KBIN to get that rollout happening. But this is an important moment where we tell you all that the birth equity training that's provided within 4th trimester is extraordinarily important. It's standardized training, which when we did the research and we looked across the state and nation, this is one of the only ones nationwide that's based on state data, but also really hits the marks of what should be trained and learned with your staff at your hospital. So again, those of you that have taken the training, you know how phenomenal it is. I promise you we're working hard to get it rolled out to the state or statewide. And I owe you this information again as soon as we get ready to roll it out. Next slide. Next slide. And as a reminder about your report card, which was kind of about the other slide too, Carrie and I are meeting both in groups with our cohort. We kind of separated our now 33 sites out so that you would have a direct, quicker access to Carrie or I, but also we will be talking to you about how we can help get all of your sunflower petals yellow. And if you have direct questions or concerns or anything, collaborative options that you want to connect with us, that's why Carrie and I are here. And so please connect with us, jump in on Carrie's. If you're in Carrie's cohort, Carrie's got a great open hours, office hours coming, and we'll talk about those things as part of the conversation that day. Next slide. Just a reminder of what's been done in our 4th trimester work, what's coming, and for our new enrolled sites, don't be overwhelmed. You can get caught up pretty quick, and they're doing it. Those folks that have just enrolled, I've talked to a couple just today, and they are ready to roll. So great. But again, those of you that have been enrolled for a while, sometimes it's helpful to know, what am I doing? The petals idea. Also, what have we already done and what's coming up next? Just keep reminding you. So hopefully it seems pretty streamlined and easy to understand. All right, next slide. Finally, we get to the important person involved with today. Very, very excited to introduce you all to someone who was, I'm going to call her a surprise, wonderful surprise, and a surprise expert in this work. I met Emerson Frazier at Stormont Vale regional meeting and heard about her in other meetings and started to be interested in her work. And without taking thunder from her, I will tell you that Emerson needs to be on the national scene. Emerson has a significant amount of background, but also great insight into a very specific part of our work. She serves right now as the Director of Health Equity and Policy at the Stormont Vale Health System. And I've asked Emerson to start off her conversation by telling us a little bit of her background, how in the world she got into this work, and then lead us into a great conversation about health equity and data today. So everybody, welcome Emerson.
Well, thank you so much, Tara, for the opportunity to speak and that warm welcome. I so appreciate the opportunity to talk to all of you experts in the room. I just feel so humbled and grateful to be able to have this conversation and share some of the work that we're doing at Stormont. In the hope of achieving health equity and better data collection as well. So that's what I'm going to be talking to you all about today. And just to give you a little bit of background to me, I am from here in Topeka. I grew up here. I left for a couple of years to pursue my undergraduate and graduate degrees in South Carolina. And while I was pursuing my graduate degree, my master's in public health, I embarked on a administrative internship at Stormont and really got immersed in a culture and was given a project and a focus around health equity and really delved into the topic. It was something I was familiar with, had been interested in studying and observing, and it was really amazing to have the opportunity to expand on such a large footprint at Stormontville and be able to kind of run with my ideas and have that leniency. And so I am now the director of health equity and policy. So my background is in public health, policy, political science and management and healthcare administration. So this really fits into my background and my interests, and have been having a really great time collaborating with people like Tara and so many other great minds as well to share some of the things that we've been doing today. But yeah, I've been at Stormont now for a little over 2 years and in this specific position for about a year, and have just really enjoyed my time and opportunities like these where I can see so many other people that have the same passion as me. And I'm seeing lots of familiar faces and familiar names in the chat as you all are explaining your names and where your organizations are. So it's really great to be in the company of good colleagues as well. And so I'll get started on my presentation. So next slide, please. Thank you. So I'm in the room with a lot of quality leaders, so I'm sure health equity isn't a new topic for probably anyone here, but I don't want to miss the opportunity to level set and really have a shared understanding what I mean when I talk about health equity and what each of us are talking about. So for me, health equity is the absence of unfair and avoidable differences in health between subgroups of population. And also, I like the definition that the Robert Wood Johnson Foundation uses of health equity, meaning that everyone has a fair and just opportunity to be as healthy as possible. So when I think of health equity, I think about top things of avoidable differences in health outcomes, systemic causes for those differences, and also the use of data as a backbone to help not only identify, but use progress as a means towards achieving health equity or more equitable outcomes with health disparities. Next slide, please. So I love to explain, where we as an organization stand with health equity and how it continues to speak to our mission, vision, and values at Stormontville. So our vision at Stormontville is to be a national leader in providing compassionate, high quality, and efficient integrated care through collaboration that results in a healthier community. So to me, when I read that, it screams health equity. Health equity is at the forefront of any healthcare leader now. And if you are achieving equitable outcomes and pursuing that, you are a leader. So that is a check there. Also, compassionate care is using equitable data and policy changes and program development to impact the most vulnerable patients in our population. Also, high quality, with this group being focused on quality. I'm sure this is huge. If you are having high quality outcomes for one group, but not necessarily for another group, it's not really truly high quality at all. So ensuring that no matter what background a person comes into our healthcare system with, ensuring that they have a great experience and great outcomes speaks high quality. Efficient integrated care. This is something that, we can't just use any kind of data. We have to make sure that the data that we do use is equitable and for our systems to be successful. And then collaboration. We know when we're looking at social determinants of health, healthcare, what we do in the four walls of a hospital is really 10 to 20% of what encompasses a full person's health. So it's not just going to take a healthcare system. It takes all of us to achieve health equity. Next slide, please. Additionally, health equity has been something that has been included in our strategic plan for a handful of years now, and every single year gets more focused, more intentional, more challenging, which I think is a really great thing. And so the specific goal that we have is probably a little bit gibberish, but I did want to denote that essentially we are wanting to expand and increase the robustness of the data that we collect in order to have better data to apply to a health equity dashboard. And I'll be diving more into this later in my presentation. Next slide, please. So I talked to you all about my start at Stormont as an administrative intern. And the first thing that I was given was a project that said, hey, we want to be leaders in health equity. We've been hearing this thing about a health equity dashboard. How can we achieve that? And I said, okay, we need to pump the brakes and first do a full evaluation on all the data that we're collecting and seeing where the holes and opportunities for improvement are. So I did different interviews and deep dives and focuses on best practice methods, and found that we really had 5 themes for improvement that really needed to be solved to have the most robust data possible. The first issue that I saw was that we had really ambiguous racial groups. The groups that we had, and you can see the example of those on my right-hand side, and it really wasn't super representative of the population that we serve. There were several groups who couldn't find a category that fit their need and their racial or ethnicity background. And because of that, there was a lack of data that was available to us. Also, we didn't have a good process for validating the data that we did have to make sure it was correct. So it was a challenge to utilize data that may not be validated. So we were underutilizing that data. Next, with Epic, Epic had a huge hurdle with validating patients who selected multiple races or ethnicities. And because of this, they were either underrepresented or overrepresented. It was kind of funky how they were using that data and how it was reapplied when we spliced and diced it. So we had challenges within Epic and also challenges when we went to run reports, ensuring that we understood what our population was made up of and how we could attach what those outcomes were to specifically. And so I did want to talk about as well, the way that we collect data is not unique. This is a way most people probably still do collect data. It is in line with what the Federal Office of Management and Budgeting, who sets guidelines for the collection of race and ethnicity data collection at the federal level. Many other organizations follow their lead because, of course, it's a federal guideline. So when you send out regulatory reports, it's just easy to fall in line with what is standard at the federal level. And these requirements were set in 1997. So it's been 25 years without structural changes to these standards. However, just last year, they have started the process of engaging stakeholders and asking questions and holding community forums with better ways that we can collect data. And even though I had already found information that I'll go into in the next couple of slides, it was they have come up with a better way that I'm hoping will be released and announced soon, and will be the new standard for data collection that's a much more robust. Secondly, we were facing lots of regulatory changes through CMS, and they were really standardizing and raising the bar for what organizations were expected to do when it came to health equity, which I think is a great thing, so that even smaller organizations who may have have smaller amounts of resources would still have a place to start and an understanding of how we can continue to achieve health equity. And then lastly, it's just changing the way that data was collected, because we knew that the way that had been standard for the past 25 years wasn't really working with us. So changing that had soon become best practice. And so I went on a deep dive to find what worked best for our community as well. Next slide, please. And so in finding that, I decided to join a collaboration through Vizient, and they had a health equity accelerator collaborative. And a part of that collaborative was doing an assessment through Vizient of our data collection efforts. And surprise, surprise to probably no one, they found the exact same issues that I had previously found with the data. So even though we did see lots of opportunities for improvement, it was a positive that we had already identified them, and there were things that are fixable for these. So these aren't permanent issues. These are things that we can implement different programs and policies in order to improve these areas. And we have spent the last year doing so. Next slide, please. So I hope it's okay to have a little bit of collaboration and a little bit of interaction too. There's really not a super right answer. It's just, this is an activity to really get us thinking about how confusing data collection can really be, especially with individuals who may not have what we consider to be traditional races or ethnicities, especially in Kansas. So this is an example. I'm sure everybody knows who this is. This is Elon Musk. He's the founder of Tesla. I think he still owns Twitter, TBD on that, but most people recognize him. And if you don't know, he is originally from South Africa. His father is from South Africa, and he has a Canadian mother. And so he later immigrated to the US and became a US citizen. So with this, if Elon Musk walked into Stormontville Health, considering the answers that we have and options for race and ethnicity data collection, which option do we feel like he should choose? And feel free to come off mute and give me your thoughts. I'd love to hear what you're thinking. Non-Latino white. Okay, I see that in the chat. Does anyone else have any other suggestions? Yeah. Okay. I would say that when we look at Elon Musk, I think we all feel pretty comfortable saying that he is ethnically white or Caucasian. However, when we take into consideration his, choose more than one, that's a really good answer. So when we take into consideration his background of actually coming from Africa and then later going to America, a lot of people might think that Black or African American would be the correct choice that he should pick because of his background of country of origin versus his ethnicity. So these conversations of what is race, what is ethnicity, how are we as organizations defining those terms isn't as simple and straightforward as we may think it is, specifically for other people situations that we may not see on an everyday basis. I have another example too on the next slide, please. So this is another example of a multiracial family. So the woman, her name is Nicole, and she was born in America, but her parents are of Indian and St. Lucian descent, and her husband's name is Ben, and together they have 3 beautiful children. So if Nicole and Ben were to be patients at Stormontville, their children were to be patients at Stormontville, what categories of race and or ethnicity would they choose? And feel free to, again, come off mute, say your suggestions in the chat of what you think. Non-Latino other, okay? Any other suggestions? And I don't know is an acceptable answer too. Okay, wait a couple more seconds. Yeah, so the answer is it's complicated. This background, race and ethnicity background, is not really represented in our data. And think of, instead of Indian, which is typically categorized under Asian, think about the breadth of experiences, the breadth of ethnicities that can be involved in each and every one of those groups, and how it can be confusing to categorize someone. But also, maybe instead of Indian, consider if Nicole was of Syrian and St. Lucian descent. What would we categorize her in? There's not an area for Middle Eastern or North African section, and this is a large group that is represented in our population here, where I am in Topeka and in our nation, and they are a group that have been basically erased from the data. How can we continue to identify different groups and have representative categories for them to choose from? So another thing I want to point out is that in this specific example, one thing that we also identify at Stormont was an error in the way that we were collecting the data. Understandably so, people can be uncomfortable with conversations around race and ethnicity and asking those questions to patients, and even patients can be inflammatory in their responses. So I understand that, but also we want to be accurate in our data collection, and that means it has to be self-identified by the patient. So we have to have the conversation. But there were instances where people didn't want to have the conversations, and they would look at the individual, the patient, and select what they looked like and what they thought their ethnicity was instead of asking. So you can imagine if those children came in with just their dad or just their mom, the wide array of different answers, mostly probably very inaccurate answers, would be associated with that data collection, and how that can really skew your data as well. So I hope that this helped to kind of clarify what we mean by confusing data, and how sometimes it just doesn't make sense and it's not super straightforward. Next slide, please. So going into what our solutions and things that we're doing to help at Stormont, again, after seeing the issues that we had, did a really deep dive into what the data and what the research was saying, and found a really comprehensive study done by researchers that worked for the census. This was a study back in 2015, and they evaluated the different ethnic groups that we typically have in America, and also how they're represented, and did surveys of different groups to identify, what do you identify as, and how or do you define your ethnicity? How do you define race? And they eventually came up with the list of ethnic backgrounds and racial groups that you see on the right-hand side. And this is basically what we decided to adopt word for word, with just a few changes. So the biggest difference between, one of the biggest differences that you see between what we did in the past and what we've moved forward with, is the addition of a Middle Eastern and North African category. That was something that was important. Again, they have been a group that has not really been represented in the data. They were expected to file under white, and most of them do not identify as such. So having a separate category for that was super important. Secondly, something that I think is also probably very obvious is the expansion of ethnicities that we were able to collect in EPIC. And it definitely was through trial and error, but with some customizations, we were able to add all these additional options into EPIC in order for our patients to have more representative options. The next thing we did was define our categories. What do we mean by Asian? What do we mean by multiracial and biracial? What do we mean by Hispanic and Latino? And even if we're not able to capture every single option, every single ethnicity under each racial group, it was very important that we define that and expanded on that. So one of the, for example, for biracial and multiracial patients, one thing that was important was for us to define how many generations back we wanted to go. What we didn't want is for individuals to identify races or ethnicities that had been reintroduced into their familial line for maybe 5, 6, 7 generations back and weren't really representative with their identity. So having that definition of if it wasn't represented in your great grandmother or before, it probably isn't going to be something that's significant and for our data purposes and defining that. So just having an opportunity to see this, and what we decided to do was print this off, double-sided, and laminate it and disseminate it throughout the areas that this data was being collected to not only be a tool for our team members, but also be a tool for patients to look at and see what we collect and the options that they have, especially when they're in person and can't see the full list, so that they can make the best informed decision for them. One specific difference that we differed from what the census group, research group did and what we decided to do at Stormont was change what we define for ethnicities within our indigenous group, so American Indian and Alaska Native. So basically the census recommended that people write in if they had any tribal affiliation. Well, that would create lots of challenges with how people, if they were to do shorthand or had a spelling error within our personal EHR system. So we decided to clarify and make it a little bit more streamlined by identifying local tribes within our service area that would be likely to identify with that population. So that was just something that made it a little bit more streamlined. Okay, we can go to the next slide. Another thing that we decided to do was to implement training to help our team members become more comfortable having that conversation about race and ethnicity and also other topics of data that we collect as well. So what we found is these were pretty common responses that people would get when we asked about these topics, and we wanted to equip our team members with good responses that they could say that would help clarify what we mean, help inform that, you know, this information is absolutely optional. You don't have to give it to us, but it can help improve your care, and it does help us to create programs and strategies to make your care better eventually. So that's what we were trying to do, and our team members have access to this response matrix in case they're in a sticky situation where they need something that's not only encouraged by Stormont, but also given by Stormontville leaders saying, hey, use this as a tool to navigate these situations. Next slide, please. Next thing we did to just kind of give our patients a heads up that this was something that was coming down the pipe and give them all the tools and resources that they needed to feel comfortable giving that information if they so chose. So we decided to launch a marketing campaign called We Ask Because We Care. And this is not something that was created by me. This is a national campaign that has been adopted at many different healthcare centers under the same name, We Ask Because We Care. And essentially, it's a movement to help inform patients about what it means to give demographic information. So it doesn't have to necessarily be strictly about race and ethnicity, but it can also be about language, country of origin, sexual orientation, gender identity, social determinants of health questions. So all of these topics that can be very, very sensitive, helping to explain why we collect them, why we're asking the question, that it's protected, that it's private, it's not going anywhere, but it can help us to improve care through other health equity measures. So if you come into our healthcare system and you see a screensaver slide on the computer or any other digital product at Stormont, you'll likely be seeing this. And this was something that we launched on May 30th. Another thing we had the opportunity to do was talk on WIBW, our local news channel, and do a 2-year health segment to help inform patients about the incoming questions that were changing and how we were going to check back in on those to revalidate our efforts, and some of the other programs that we're doing around health equity and community health improvement. And then lastly, we created a FAQ page and just a landing page for someone if they had very specific questions. That would be their hub to get not only the questions answered, but also more resources on what other healthcare systems have done with the We Ask Because We Care campaign, and how it ultimately benefits them as a patient. Next slide, please. So kind of the application of this information is the next stage of my presentation that I'm hoping will be helpful. So one thing that has related to our health equity efforts has been our participation with the March of Dimes Maternal Healthcare Collaborative project. And we have been participating in this since March of this year, I believe, and it goes through 2025. And it is a project, and we're the second piloting group to have done it. It's been a really great opportunity. And essentially the program's aim is to reduce racial inequities and disparity gaps in outcomes for Black birthing people. And they have the ultimate goal of improving Black maternal health outcomes during the birth hospitalization. So they really create a whole wraparound collaboration of projects that we as a healthcare organization can do in order to reduce these disparities. So we're looking at staff, patients, community engagement, and so much more data collection. So we collect maternal health data, so that directly aligned with the work that I did with increasing the robustness of the data we collect. We're specifically looking at the Black population, so having accurate data around that was imperative. Oh, I guess my watch wanted to talk in the presentation too. Also, we were tasked with forming an anti-racism work group. And so this work group, we would look at 4 metrics of creating a statement specific to the birthing person, looking at our policies around hiring practices, our marketing materials, reviewing of events, that kind of thing. Implementing team birth, which would really integrate the patient and would make them in the driver's seat of their care and inform them and give them a seat at the table when decisions are being made. Community accountability panel, so that's the community involvement. So people that are anonymous giving us feedback on how our changes are being perceived in the community. Education calls every month with subject matter experts, and also implicit bias training too, which is just starting today and will go for the next several months, and is really training our staff on implicit bias and also maternal justice work as well. So we can go to the next slide, the slide after that. Yeah, so on that same conversation about application is talking about this dashboard. So I've been referring to this throughout my presentation, and I'm a visual person. So we're going to explain what a dashboard is and also what it can look like as well for a quick second. So essentially a dashboard is a tool that is able to capture progress and identify areas of focus. Additionally, you can do a continuous addressing of gaps in care through how you identify the patient population and certain outcomes that you want to measure. So it can capture progress, identify trends and risk, help understand our populations, and also drive policy change as well. Next slide, please. So this is an example dashboard that we did with our internal data, and want to say a huge caveat before we start with the internal data. This was collected before we started our project around increasing the robustness and the validity of our data. So, you know, I feel in the role of health equity, sometimes you have to work with the data that you have. And if we wait for interventions until we have perfect data, then we'll be waiting for forever. But this is a start to kind of see where trends are loosely. And as we continue to improve data, we can continue to track these and see how things have changed over time. So this was just an example dashboard to show what a dashboard can do. And this is around the topic of low birth weight in Shawnee County and comparing our county health rankings data. So you'll see on the right-hand side, this is an excerpt from the actual county health rankings about where low birth weights are looking depending on an individual's race, and how there are very distinct disparities between the Black population, double most of the other racial groups. And that was definitely a population that was identified as having a disparity in this specific outcome. Next slide, please. So we looked at zip code specific data. So these are just different ways you can display that. On the left side, we did a county map based on zip code. And if the higher the low birth weight that you have, the darker the color is. And what's interesting is that red circle identifies where the highest rate of low birth weight is, and that star identifies the approximate location of Stormont, our Topeka campus. So just seeing how close those different groups are, and how it's really in our backyard, and the opportunities that we potentially have to wrap our arms around that specific population. And then the line graph on the other side is showing the exact same thing, just a little bit simpler. And so you see that specific number is 23.8. So 2, 3, 4, 5 times that of other counties and other areas. So a very distinct disparity there. Next slide, please. And we also decided to splice it by race and also the mother's age group. So the largest ones that we had for race were Asian and Black or African American. And just also want to point out that the sample size group of Asian and American Indian, Alaska Native populations is pretty low. So definitely room for outliers there. I feel like the Black African American population is pretty representative. It's a good size, so that's probably closer to what it would be. But just seeing like the differences between what the county health rankings had and internally what is the data is looking like, even with imperfect data, we're seeing similar trends. Again, for mom age group, I feel like that pretty much is the bell curve is expected, with more average ages having lower risk groups, and younger and older moms having higher risk in this area. So pretty much expected, but still definitely room for improvement there. So the next slide is the end of my presentation. So I appreciate the opportunity to speak, and happy to answer any questions about our approach, our research, and what we're trying to do and accomplish within our health equity sphere here at Stormont.
Chat is open for questions.
Emerson, I'll start with questions. How did you get your team on board with building all of the different components needed to address the racial demographics within EPIC? we just launched Epic in March. And so I'm interested in finding out how you guys all collaborated on that.
Yeah, I would say the support definitely came from the top down, and with the leadership support and it being included on our strategic plan, there was really a consolidated effort in that project, and that was something that was absolutely essential to get that done. So I think that really helped. Additionally, I think explaining the why we're doing it, how that collection of data can impact health equity metrics is really important too. I think because the way that we've collected race and ethnicity data has stayed the same for so long, sometimes it's hard to wrap your head around how much it can impact other things that we do now that there's a huge focus on health equity. So bringing in that why factor, I think, was also super important in how it can directly impact quality and outcome metrics for our patients too.
Great, thank you.
Of course.
Hi, Emerson. I have a question regarding so you guys have the project that you're working on with March of Dimes, and then we have this kind of going on with KPQC. Like, in your job, does it flow over to other areas of your hospital? And is it fair? Because I feel like there's a lot going on in the OB mother baby world of this. I don't feel like I hear counterparts of mine in other areas of the hospital focusing in on these subjects, or on this subject in like we do in our area.
Yeah, that's a great question. So to answer your first question, yes, there is a whole lot of collaboration between our departments. And I am, since my role is so new, I am the only person on my team working specifically on health equity and policy. So I have to have collaboration in order to get anything done, and have to have collaboration specifically of subject matter experts who are patient facing, because I am not clinical. So having that perspective is super, super important, and having their buy-in is, I think, essential. So specifically for our March of Dimes collaboration, we are looping in my area, so health equity, policy, and I don't know if I explained this earlier, but the policy part of my position is around legislative relations and policy, that is public policy, so laws being passed, things like that. So having that aspect is super important too. We have community engagement, we have clinical leaders, we have marketing and communication, administration, just so many other areas. And then like for just the data portion, we had to get registration involved, quality involved, nursing leadership involved, and so many other people. So I find that when we have huge collaborative efforts and the buy-in of all stakeholders, these projects, it may seem slower at first because you're including so many more people, but the end result will be so much more successful when everybody's on the same page and understands the vision. I think did I answer your second question as well?
Yeah, I think that makes sense that you would have like a lot of those areas that are interwoven into like how we pull the data and get that information out there. And I think it's fascinating. I don't know, baby friendly, I feel like help really get us kind of tracking in the right direction and like dividing out our information and our data. But like when I talk about like what we're working on in like OB compared to what they're doing in cardiac care or surgical services, that kind of stuff, it's a lot of the educator people in those areas that are kind of a similar job to me don't have the understanding as much, or they're not relying I don't know, doesn't feel like there's stuff that relies on the data as specifically as we do.
Yeah, that's a good point. And I think that there's definitely room for greater education and understanding and collaboration between disciplines as well. That's a good point.
Are there any
Emerson,
other questions for Emerson?
yep.
Sorry, Sam.
Nope. I saw you go and I tried not to go at the same time. It's like playing Jeopardy with you. Emerson, phenomenal job. I think again, you have silenced the crowd with your brain work. Dr. Donna Pui makes a good point. And you and I have shared this conversation. Part of the barrier is also the benefit, right? Instead of pen and paper charting, we're computer charting, but the system sometimes creates a difficult change in how we ask patients specific and document certain things. So I think the most fascinating slide that you've added to this is the extensive list under each category. And I was sitting here thinking, I have no idea how much time that would have taken you and how many different people you would have had to include, but it's extraordinarily important. I think that by itself would be helpful nationwide. And just for everybody on the call to think about, when we started the AIM bundle at the national level, keep in mind that's ACOG, that's the heavy hitters in OB world. As part of the decision tree, we asked them specifically about the racial demographic questions that are part of our bundle and how they wanted us to report. And I will tell you, there was no answer. And so part of what Emerson's doing is, I would say, the ground up work to try to figure out the age old question of how do we ask the question, let alone how do we document the question and the answer to that. So I'm hopeful that all of us that are own sites can figure it out. Now, how we've screwed that up is that you are supposed to input data, racial demographic data at some point throughout 4th trimester about your hospital discharges, those of you that are enrolled. And as I listened to this today, I realized that we've barriered you. But again, that's what the national response is supposed to be in that bundle. But I would encourage you to not use that. I would encourage you to do what Emerson's doing at Stormont. So great food for thought, Emerson. Any final questions before we let you guys go?
Well, thank you so much for the opportunity to come and chat with you all today. Again, so good to see colleagues as well that are familiar and have really robust discussion. And to your point, Tara, I'm really hopeful that in the future, especially with the adoption at the federal level of a very similar model to what we're doing at Stormont, that we will see that nationwide adjustment to more robust and granular and inclusive data collection. So I'm really excited to see that and appreciate you guys highlighting this issue as well.
Hey, Emerson, are you comfortable putting your email in the chat for everybody? And of course, it's on the slide deck, I think. And if not, we'll make sure that Tiffany, we can send that out if you're comfortable. All right. So this is the boring tie-in where I just get to tell you the next steps because Emerson's awesome. You don't want to hear anything else, but we want to have you back. We are going to follow an awesome topic up with another awesome topic. Carrie, our own Carrie Smith, is going to lead a topic discussion about this elusive OBER collaboration and how in the world these two very highly functioning units oftentimes do not talk to each other, and we really want them to. The data is clear. This is a catastrophic problem in Kansas, that patients will show up to our emergency departments in the postpartum setting and folks don't know what to do or who to call, or there's no OBER collaboration. So Carrie and her colleagues are going to attempt to open that can of worms, fix the worms, and put them back in. And we'll do that on August 22nd. You guys have a great day. Tiffany will share all of this out in the coming days, and we look forward to seeing you in a month. Have a great day.